Welcome to PodcastRx, a production of Diamond Pharmacy Services. This is a show about pharmacy, but don't let the title fool you. While we definitely talk with pharmacists about medication topics, we also sit down with nurses, technicians, and other pros to discuss relevant issues in corrections health, long-term care, and so much more. Whether you're a pharmacist, a practitioner, or just find these things fascinating, this is a show for you. On this episode...
So when we talk about this, it's really important to understand that drug diversion can really be performed by anybody at any step along the drug's journey from manufacturer down to the patient.
No matter who is doing it, the illicit transfer and misuse of medications is an issue that greatly threatens the safety of both patients and healthcare providers. Chris Bender and Erica Gray of the Diamond Drug Information Center join us to discuss drug diversion in institutional care settings and what providers can do to defend against it.
For example, it can happen in the pharmacy, it can happen at hospitals, outpatient practices, long-term care facilities, personal care homes, ambulance services, and anywhere else within the healthcare network. Overall, diversion can happen anywhere and that there are medications. So that's a big thing to remember.
In the first segment, we define drug diversion and get a truly eye-opening look at the ways both prescriptions and OTC meds can be diverted in the correctional setting. And in the second segment, we talk about diversion among healthcare workers and the resources that facilities can use to build a strong diversion prevention program. I'm Ashley Fritz, and this is PodcastRx. Welcome to PodcastRx. I'm your host, Ashley Fritz, and I'm here today with Erica Gray and Chris Bender. Both are PharmDs, both work with our Diamond Drug Information Center, and both have been on our show before. Guys, welcome back.
Thanks for having us.
Thanks for having us.
So today we are going to talk about drug diversion. I think it's something a lot of us are moderately familiar with, so let's just start with the easy question. Can someone please give me an overview of what drug diversion is?
Yeah, sure. So I can start us off with that. So drug diversion is basically any act that removes a prescription drug from its intended path, from the manufacturer to the intended patient. So to put it simply, drug diversion is really just a person illegally taking a drug that's not intended for said person. So when we talk about this, it's really important to understand that drug diversion can really be performed by anybody at any step along the drug's journey from manufacturer down to the patient. So it's probably easiest for us to encapsulate this concept by breaking the journey down into three phases, right?
Okay.
So we have the manufacturer level, the healthcare level, and the patient level. So for example, drugs could be diverted at the point of manufacturing within the drug company itself. Perhaps more commonly, however, drug diversion may be performed by healthcare providers like doctors, nurses, clinic staff, and even pharmacy employees. But the risk for drug diversion doesn't stop once the drug is in the patient's hands, as we all know, because drugs may still be diverted by individuals like family members, friends, or neighbors.
Of course. Okay. So you have to wonder, this is something that's probably been a problem as long as we've had pharmaceuticals and prescriptions. You have to wonder if the recent issues in this country with addiction have maybe kind of fueled our spotlight on drug diversion and kind of really paying attention to what you're describing, like the path of the drug from manufacturer to the end user. But stereotypically, kind of with that in mind, what types of drugs are typically most at risk for being diverted?
Yeah, so I think to put it simply, the most commonly diverted or abused medications are those that are considered to be controlled substances. And of course, we know there are quite a few of those.
Right.
Now, this kind of makes sense, right? Because medications that are considered controlled substances by the DEA, they're considered controlled substances whenever they have high levels of abuse potential. Mm-hmm. So I think a lot of these are pretty intuitive, and they're what we tend to think of first when we think of prescription drug abuse. So these drugs can really be broken down into a few key drug categories. Obviously, the most notable, probably the ones that we see the most frequently in the headlines, are the opioids.
Of course.
And of course, these include fentanyl, oxycodone, codeine, morphine, and I even include tramadol in this as well. even though it's a weaker opioid.
Please correct me if I'm wrong. I just interject for a minute.
Yeah.
The fentanyl that you're speaking of, this isn't like the street grade fentanyl that we hear about in the news.
Yeah, so these are your typical fentanyl patches that you often see in patients with cancer, or you even see them in the nursing facilities a lot too.
Right.
Along the same lines, in terms of opioids, it's also important to recognize that those medications being used for opioid dependence treatment are also included in this as well. Medications like buprenorphine or methadone, those would be included in drugs that are commonly diverted as well. But there are a lot more controlled substances, some of which are depressants, like your benzodiazepines, your sleeping medications, like your Ambien and stuff like that.
Sure.
And even lesser known medications like anticonvulsants, like phenobarbital, which is an older medication but still has abuse potential. And then you have medications that are stimulants, like your ADHD medications, like methylphenidate or amphetamine. And then there are a couple other kind of oddball ones too, like you have ketamine, which can be a hallucinogen, and even things that could be diverted for non-euphoric purposes, like testosterone, or other anabolic steroids like that. So this, of course, is not an all-inclusive list, obviously, but rather they're some of the more commonly identified agents that we see. In fact, there are many non-controlled medications that are subject to diversion risk as well, but I think we're going to be touching on those actually a little bit later.
Sure. And I want to talk to you guys about, the population that you deal with a lot are correctional healthcare professionals. I can only imagine that's a demographic. This is just a rampant problem. So in the correctional setting, what are some common ways that drugs can be diverted?
I think this is a really good question. Honestly, when I started working in corrections, I felt like I was pretty naive to all of this and all of these creative ways that we hear about patients diverting medications within the correctional setting. I just want to go over two resources that I looked to whenever I started out in the correctional setting.
Yeah.
One place that I turned to for insight on methods of diversion was Dr. Jeffrey Keller's jail medicine blog. So Dr. Keller is a physician who works in the correctional medicine, and his blog gives some really good real-world insight to this unique healthcare environment. And then there's also another nice publication. It's written by O'Hagan and Hardwick. It's called Behind Bars: The Truth About Drugs in Prison. It was published in 2017 in the Forensics Research and Criminology International Journal. And this article will give you even further insight to how drugs and drug diversion occurs within the correctional setting. So now I want to get into some of the methods that we've heard of. So particularly whenever we're talking about tablets and capsules, people can avoid swallowing the medication and then store it on themselves like in a body cavity.
Sure.
I don't know if you've heard of the term cheeking.
Yes.
Yeah, so that's a pretty common term that we'll hear with patients if they're diverting medications. So it's a term for concealing a medication in the mouth between the teeth and cheeks, and then they avoid swallowing it. So then they can take the medication and hide it on themselves later on. And then also patients can utilize denture cream on the roof of their mouths. So when they are given the medication, they can kind of just push the pill up into the denture cream because it's really sticky. And then if a patient's missing a tooth, they can store the pill in an empty socket, in that empty tooth socket. Some patients are actually really good at regurgitation, so they can take the medication, then regurgitate it and use it for later. And then whenever they go to swallow a pill, sometimes they're given a little cup of water.
Yeah.
So they can swallow the water, but then spit the pill into the cup and then kind of do like a sleight of hand or palm the pill and then store it on themselves later. And then a lot of medications can be crushed to avoid diversion. So that's commonly what we'll try to do with these patients. If we catch them diverting the medication, we'll make sure that we crush it and float it in water if it's possible to be crushed. But some patients are actually able to retain the powder on their tongue, and then they'll kind of scrape it off for later and store it for later. I actually heard about a patient that was getting liquid medications. He was storing a cotton ball in his mouth, and then the liquid medication was being absorbed in the cotton ball, and then he was wringing it out for later use. And then we've also heard about people just taking a medication and then selling their spit later. And then we also have to think about other ways that drugs can come into the facility besides the prescription line. I know that's where we heavily look at as pharmacists, but there definitely are other ways. You have to think about other people that come into the facility, like visitors that come in to see the patients, so it can come in through visitors, coming over the prison walls. So there's reports that have drones have been used to drop things in, tennis balls being thrown over the gates, and these tennis balls are just filled, with sometimes substances.
Sure.
Anytime a prisoner comes in and out of the facility for reasons like court visits or after being released and arrested again, for example, reports of patients storing medications in body cavities or swallowing balloons filled with drugs prior to coming into the facility. So then when they're in the facility, they pass the balloon that's filled with those drug substances. And then prison staff could be bringing in items. Mail is probably one of the most interesting ones that I've heard of, where they were spraying drugs onto the mail or pictures that were done by children, and that has just substance on it that they could use or abuse later. And then also being applied to back of stamps is another way. But I'm sure there's probably even more creative ways that I've not mentioned as some examples that people can bring things into the facilities.
Yeah, it sounds like there's definitely, unfortunately, a lot of creativity around this and a lot of commitment for this kind of drug diversion. And I'm certain that the creativity also can go into the types of drugs. We kind of talked about the obvious ones, the ones that are for the high. But in that unique environment in corrections, I'm sure that outside of that, there are some basic therapy ones that get abused. Chris, can you speak to that?
Yeah. So of course, like you mentioned, there are, well, as we previously mentioned, there are those medications that are pretty intuitive. They have high risk for abuse. So those are, of course, the ones that are, more frequently abused. And it's for that reason that those, controlled substances are typically used less frequently in the correctional facilities. So for that reason, like you just said, people trying to misuse medications in the correctional facility have actually become a little bit more resourceful, using medications that are typically not thought of as having a very high abuse potential, or in other words, normal, non-controlled prescription medications.
Right. So something I could probably go into a Walmart or a CVS to buy.
So it's good. It's good to note, however, that there are a few medications that, while they're not controlled substances, they do still have an abuse potential. These are widely used in the community, and for that reason, they have a high rate of diversion in the correctional facility. And these three agents that I'm talking about specifically are gabapentin, quetiapine, and bupropion. So gabapentin, which is a very commonly used medication for neuropathic pain, sometimes seizures, when taken in high enough doses, can cause euphoria or an elevated mood. Now, the next one, the antipsychotic quetiapine, is often known as being highly sedating, often referred to on the streets as baby heroin, in fact. And then third, the antidepressant bupropion is actually a very stimulating antidepressant. So for that reason, it often produces a quote-unquote high similar to that of cocaine, but of lesser intensity. So I highlight these three because I think these three agents nicely highlight the major reasons why medications may be diverted in the correctional facility. So typically they're being diverted for either sedation, for stimulation, or for euphoric or psychedelic reasons. So Erica, perhaps you can mention some of the other medications that may be diverted?
Yeah, of course, Chris. I'll list some of the other ones. I'm just going to go through and list these, but I just really want to reiterate the ones that Chris mentioned are definitely the ones that we probably highlight more and look at because of these reasons. But he talked about like sedation effects of these medications. So there are other sedative like agents that we have. So thinking about antidepressants, everyday antidepressants that people typically use, things like trazodone, mirtazapine, amitriptyline, and doxepin all have sedating effects that could be abused. For that reason, muscle relaxants and clonidine also have sedating effects. Right. There's agents that have stimulant effects. So things like albuterol inhalers. People use these for like COPD and asthma. Pseudoephedrine, which you probably get over the counter at the pharmacy. And then agents that have euphoric effects. Antidepressants, again, I'm going to mention trazodone here. Another antidepressant, venlafaxine, and then anticonvulsants, such as topiramate and carbamazepine, have been reported as having euphoric effects. And then loperamide, which is an antidiarrheal agent, when used in large quantities, can cause euphoric effects. And then lastly, psychedelic agents. So our antihistamines like Benadryl or diphenhydramine, hydroxyzine has psychedelic effects when used in like high quantities. And then anti-Parkinson's medications. So benzotropine, hexafenadil or Artane, oxybutynin, which is used for urinary incontinence, dicyclamine, which is typically used for irritable bowel syndrome or stomach cramping, and then dextromethorphan, which is commonly used over the counter. So just thinking about those, one of the things we really take away from this is just thinking how it could be abused and its abuse potential and how common we see it in a typical population. I also want to mention that not all of these medications are diverted for mood-altering effects. There are other medications that are diverted for other reasons, aside from just like a sedative reason or stimulant reason. So one of the really big things is like psyllium powder. Psyllium powder is typically used to help with constipation. It's a packaged product, but it actually can be wetted and then hardened and then molded into a weapon. So that's one of the really big things that we try to avoid because we don't want them to make weapons whenever they're in that correctional facility. And then some other things that you have to think about with psyllium powder is that some of them contain sugar. So this can be used for fermentation processes within prison, and then they can make alcohol from it. And then lactulose is another one, also used for constipation, but it's really sweet in flavor, so it can be used as a sweetener for like prison wine. And then lastly, stimulant laxatives like Miralax can be used. Sometimes patients will use these for weight loss if so desired.
Yeah, in reading that list, because I also, that jail medicine blog that you referenced earlier, in reading that list, I was shocked at some of the things that were diverted regularly enough that they make a list that say, and just for our listeners, we will include the links to those blogs and the resources that Erica mentioned in the show notes, so you can check them out for yourself, because while Erica mentioned most of them, there are plenty, and I'm sure there are plenty that this blog entry doesn't even cover, but it's a great place to start. So you, both as PharmDs in the Diamond Drug Information Center, work with correctional facilities a lot on a daily basis. How often are you talking about drug diversion with providers who are kind of on the front line?
I would say that we pretty frequently talk about drug diversion in the Drug Information Center. The most common discussions that we have is when a provider would like to use one of these concerning drugs that we talked about before, so like gabapentin, bupropion, or quetiapine. And we know that there are less concerning alternatives that may be used for the patient's treatment. So just as one example, we see a lot of patients coming into the facility using gabapentin for neuropathic pain, which is generally acceptable to use gabapentin, outside of these correctional facilities. However, in the facility, there would be much more diversion risk if they used a different agent that has less abuse potential. So an antidepressant called duloxetine has data to support neuropathic pain treatment, and it has low abuse potential. So we'll typically recommend one of these agents over using or continuing gabapentin. I want to send it over to Chris, and he can tell you about some of the things that we've heard or questions that we've heard regarding diversion.
Yeah, so so we've also had to handle, in addition to these therapeutic type questions, we've also had to handle questions from providers who suspect diversion may be occurring, but they're not really sure how. So for example, there have been cases of patients using biotin saliva replacement to coat the inside of their mouths prior to their buprenorphine dose, because it's a transmucosal absorption product. So we actually had to do some digging into the subject to determine that at least theoretically, this biotin product could, again, theoretically decrease the amount of buprenorphine that gets absorbed under the tongue, which would then allow the patient to then sell their saliva to other patients in the facility. So I guess all in all, it kind of comes up in all sorts of ways in our office.
We're going to take a little break now to tell you a little more about the Diamond Drug Information Center. On a personal level, we all appreciate when our pharmacist gives us a thorough consultation for a new or complex medication. They dispense not only the drug, but important information about dosing and possible interactions. This kind of medication counseling is easy to understand on a personal level, but what about on an institutional level? Where do healthcare providers, especially those delivering care to large populations with diverse needs, go when they need medication counseling? Enter the Diamond Drug Information Center. The pharmacists of the Drug Info Center dispense in-depth clinical consultation for all of Diamond's customers, from correctional facilities to nursing homes. This team of PharmDs specializes in pharmacotherapy and disease state management. And if you have questions about dosing, drug-drug interactions, non-formulary medication requests, therapeutic alternatives, or you just need general clinical advice, they're a call away. They also take proactive steps to educate healthcare professionals. They issue regular clinical updates, and they develop webinars and presentations about specific drug topics. You can reach the Diamond Drug Information Center at 800-882-6337, extension 1834, or email them druginfo@diamondpharmacy.com. And now back to Podcast RX.
Welcome back to Podcast RX. I'm Ashley Fritz. I've been here with Erica Gray and Chris Bender. We've been talking about drug diversion. And we've been focused so far, guys, on the correctional facility healthcare industry and drug diversion. But it's not the only place it happens. Is this something that we see in populations like nursing care, nursing homes?
This is a good question. I know we highlight correctional facilities a lot, as you mentioned, but diversion can and does happen across all healthcare facilities. As Chris mentioned at the top of the podcast, diversion can happen anywhere from manufacturer to patient. For example, it can happen in the pharmacy, it can happen at hospitals, outpatient practices, long-term care facilities, personal care homes, ambulance services, and anywhere else within the healthcare network. Overall, diversion can happen anywhere and that there are medications. So that's a big thing to remember.
So one area, it's one that you kind of don't want to talk about, but we have to acknowledge with drug diversion, it's healthcare staff themselves. HealthcareITNews, which we'll share the link in the show notes, they published an article last year that claimed that up to 15% of the healthcare worker population is drug addicted, which is a bigger number than the general population. So how big of an issue is this?
So I think that's a very important question to address. And in fact, I did see that article. But I think what's important is first that we dispel any a little anxiety that comes with that statistic, because the actual statistic is that 10 to 15% of healthcare professionals will experience addiction at some point in their lifetime. So we don't have 1/6 of our healthcare workforce currently struggling with addiction.
Of course.
That would be extremely
that's an important distinction.
Extremely concerning. But what that does mean is that while maybe it's not 15% right now, there are certainly more healthcare professionals currently struggling with addiction than many people would think. Most people tend to think of healthcare professionals as like these champions of healthy habits, right? Now, as far as how substance use rates compare to the general population, it really depends on the source that you're looking at.
Of course.
So some show lifetime substance use rates of 8 to 10% in the general population. So depending on where you look, you will see that the healthcare professionals are either at a similar risk of developing substance use disorder or a slightly higher risk than the general population. But regardless of the prevalence, there are still a couple of key differences that make substance use in the healthcare provider population slightly more alarming. And the first of which is access, right?
Of course.
So healthcare professionals naturally have expanded access to drugs of abuse compared to the general population. So, of course, it's easy for us to see how a person with such broad access could spiral out of control, deteriorate much faster than a person in the general population with a much more limited access.
Of course, and this is a high stress population as well.
Yeah.
It is kind of an environment that you can see how this kind of thing happens.
Right. There's a lot of pressure put on the employees, and there's a lot at stake. So a lot of people tend to use that to either boost performance on the job or even just to cope with a lot of the stress.
Of course.
Perhaps more importantly, though, beyond the first point that I made about the access to the drugs is the direct impact that it can have on patient care. Some examples of this include infection transmission from the healthcare practitioner, sharing the patient's injectable medications. So, in fact, there's been numerous case reports of this happening in which there have been transmissions of hepatitis C virus from a nurse to the patient simply from using part of the injectable opioid that the patient was supposed to get. And of course, anytime you're sharing, you not only increase the risk of viral transmission, but of course, bacterial transmission as well. But even further, there's been reports of patients receiving inadequate treatment, namely from a pain control standpoint, because if you're sharing half of the patient's opioid medication, if the nurse is sharing half of that, then of course the patient themselves is not getting adequate pain control.
Right.
And the final point is a healthcare professional under the influence is by nature not performing up to the standard of care. So the patient in a way is getting substandard care due to the healthcare provider unable to perform job responsibilities adequately.
So all that being said, what are some things that healthcare facilities can do to help combat drug diversion?
Yeah, I think one of the biggest things that a healthcare facility can do to combat diversion is knowing what medications are typically at risk of diversion. So going back to what we already mentioned in the podcast whenever it comes to diversion, knowing how medications can be diverted, and then most importantly, having a drug diversion prevention program.
So what is a drug diversion prevention program?
Yeah, so here I'm going to come at you with another a resource that is a great place for
And it
you
will
to
also
go.
be in the show notes.
Yes, it's a great place to go if you're looking at starting a drug diversion program or looking at your program and how you can improve your program. There's a really nice article that was published in the American Journal of Health System Pharmacy in 2017 titled ASHP Guidelines on Preventing Diversion of Controlled Substances. The authors, Brumman and colleagues, pretty much lay out for you strategies for a drug diversion prevention program. So that is definitely a place to go. They emphasize a couple different things. One of them being core administrative elements, having system level controls, and then also provider level controls. I'll just go through and give you some examples of what they give.
Great, yeah.
So they emphasize for core administrative elements having legal and regulatory requirements that you should uphold. So you can imagine making sure that you're fitting with all the local laws, state laws, and then federal laws whenever it comes to regulatory requirements. Organization oversight and accountability. Typically, you should have an interdisciplinary team, so physicians, nurses, pharmacists, all on a team together who are responsible for prevention, detection, investigation, and reporting. Then as for system level controls, they include things like human resource management for your facility. So making sure that you have substance abuse policies, supervisor training. So supervisors know what to look out for if they suspect that their employees are at risk or diverting medications. Assistance programs for these people and your employees that, maybe go down the path of utilizing those medications and need help. And then return to work policies are really important. And then automation and technology are also system level controls. So using our technology to help us with surveillance systems and software, record keeping that is readily retrievable, utilization of auditing software, especially in those high risk areas where we have controlled substances, and then proper training on diversion for the staff. And then other things like monitoring and surveillance also are very important. So having that dedicated staff that we talked about before, making sure that they're going through and monitoring and perpetually looking at inventory,
Right.
And they assess utilization throughout the facilities. And then evaluating prescription trends. So maybe in a particular shift, we notice that we're using a lot of opioids when a particular provider is working. Ensuring discrepancies are reported to supervisors as soon as possible and corrected as necessary. And then lastly, with system level controls, they have investigation and reporting. So you need to make sure that you understand who's in charge of coordinating the investigation within your facility, and then reporting to the correct agencies depending on what's diverted. And then also having quality improvement tactics. So looking at root cause analyses. So how did this patient or this person divert, and how can you prevent it from happening further? And then communication measures, especially if a patient was affected. So making sure that you let the patient know and their families know is very, very important within these facilities. Now, lastly, with the provider level controls that they mention, chain of custody. So ensuring only those who are authorized to have access to a particular area where we have controlled substances have access. So anytime a controlled substance is transported, you have to make sure you have proof of receipt and make sure that you have proof of drop-off. And then storage and security is really important at the provider level. Having locked and secured locations and lockout times for electronic locks. So healthcare workers, if they step away from, if they're taking out like a controlled substance from a particular automated dispensing device, and then maybe a code is called and they have to go help that patient, that if they walk away, that it locks after a certain amount of time. Limited access only to authorized personnel and restriction requirements such as passwords or biometric IDs or badges. And then surveillance systems in these high-risk areas. So, no one really likes to be on camera, but It is important that we have these in the event that something is diverted. And a lot of facilities have these automated dispensing devices that I talked about before, so ensuring restocking is witnessed and inventories are monitored regularly. And then you have to think about other things as far as like our provider level controls, prescribing and administration. A good example was having an automatic stop in place if a controlled substance does not have a specific time frame or number of doses prescribed. And then also if there's an as needed use, a lot of people will go back and audit to make sure that, say a patient has a pain scale, that the pain scale correlates to, medication being administered. And then lastly, waste and disposal is really important. It's anytime you have unused controlled substance, it should be wasted immediately and it should be witnessed. On top of this, there should be documentation for the wasting. A lot of medications also come in vials that are overfilled. So anytime we talk about multi-dose vials, there might be a little bit extra. So making sure you're still wasting that overfill of controlled substance and that it's witnessed and documented. So all of these things that they talk about are in place, and there are times when products can be diverted. So it's really important to understand when and how products can be diverted, and then using this tool, this controlled substance diversion prevention program, to make sure that these medications don't get diverted.
So it's clear there's a lot of time, a lot of resources, a lot of data gathering that goes into a robust drug diversion program. But I think one of the most important things you mentioned is training to recognize the signs, whether it be diversion with the patients or with healthcare staff. So what kind of signs should people be looking for?
So there are certainly some behavioral red flags, and these apply to both patients and healthcare professionals. So for one, we look for physical signs and symptoms of either intoxication or withdrawal. These are very important. So unexplained changes in appearance, excessive fatigue, watery eyes, weight loss or weight gain, changes in pupil dilation, or someone complaining often about lighting issues, or signs of sweating as well. You can also look for unusual or unexplained changes in behavioral patterns. So is the person having personality changes or mood swings, or do they have unusual productivity patterns? So do they have these bursts of productivity followed by absolutely no productivity? Or do they have frequent or often unexplained disappearances during their shifts or their family events? There are also additional signs on the patient side of things. And these would be if a patient is engaging in quote unquote doctor shopping, which is whenever a patient is visiting more than one doctor to get the same prescription, or if we notice the patient is routinely trying to get refills too soon from their pharmacy. But there are also some additional red flags regarding healthcare professionals as well. So some of these include unusual volunteering patterns. So the employee may always volunteer to do the control inventory, or volunteer to hold the narcotic keys. Abnormal work patterns. So they're often showing up on their off days to either finish work, or you see them making rounds during odd times. And also, as Erica mentioned, as one of the system level controls is excessive control utilization. So if you notice during a particular healthcare provider shift, you're seeing there's an increased utilization of your quote unquote as needed medications. That can also be a red flag as well.
Wow. Okay. So a lot to look for. Good information, a lot to pay attention to. I know you've listed a few things already, but if somebody out there is looking to start up a drug diversion program, are there any good resources out there for them?
Yeah, absolutely. So I would highly recommend anybody wanting to learn more about drug diversion programs visit the American Society of Health System Pharmacists website at ashp.org. ASHP, of course, produced the guidelines, as Erica previously discussed, on the prevention of diversion of controlled substances. But also on that ASHP website, you can find what's called the Controlled Substances Drug Diversion Pharmacy Technician Toolkit. And this site provides a lot of great resources, some of which are sample position descriptions. So if you're looking for hiring a loss prevention specialist or diversion project managers, it also has processes and workflow resources. So essentially, if you have any questions regarding how to prevent, but also how to handle a potential drug diversion incident, and it also has guidance for communicating with law enforcement. But what I also like about this site is that it doesn't just have resources for the facility to protect itself against diversion, but it also has resources for addiction, healing, and recovery. So I believe that while it's important for a facility to have proper steps in place to prevent, identify, and resolve drug diversion, it's just as important to understand how to help the person struggling with addiction, whether it be a patient or a healthcare professional in the facility. So it has links to resources such as startyourrecovery.org, which is a site that gives people objective information about the signs and symptoms of addiction, as well as treatment options, as well as resources for recovery. It has a link to SAMHSA's National Helpline, which is often used as a referral and information service. It can put those uninsured patients in direct contact with state offices, limited insured, with appropriate offices as well. And it also has a buprenorphine treatment practitioner locator, which is really helpful to help patients requiring medication-assisted treatment find local practitioners in their area. And lastly, I would also highly recommend facility administrators familiarize themselves with their state monitoring programs for healthcare professionals. So, for example, in Pennsylvania, we have the professional health monitoring programs, which are responsible for overseeing physicians, nurses, and pharmacists with substance abuse. These programs allow the healthcare practitioner to continue to practice. However, they require the healthcare practitioner to be closely monitored via random drug screens, participation in recovery-related activities for a certain period of time, which is often for a few years. And the great thing about these programs is they have a historically strong track record and with a high rate of success.
You know, I think these are all really good points. It's not like a drug diversion program is just a one and done thing. It's part of a bigger picture where if the root cause of the diversion isn't treated, it's just going to keep perpetuating, and you're never going to make any progress. So right. I think these are really excellent points. Also want to point out that if you haven't heard Chris Bender's podcast with PodcastRx about medication-assisted treatment therapy, you can find it in our feed. We talked about that a few months back. So we want to refer to that as well. I want to thank you both for your time here today. We really always enjoy having you on the podcast. This is a great topic, really interesting. And just one more thing I want to ask to kind of bring it back around. Both you being PharmDs involved with the Diamond Drug Information Center, how can the input of a pharmacist help with the creation of a drug diversion program?
Yeah. So first, it's recommended in the guidelines that an organization establish what's called an interdisciplinary controlled substance diversion program committee to essentially provide leadership and direction for developing policies and procedures for overseeing the program. They go on to suggest committee members to include staff from medical, anesthesia, pharmacy, nursing, security, human resources, compliance, risk management, administration, legal, media/communications, information technology, and employee health. So it's really
pretty much everyone.
Basically everyone in the facility is involved in this. So clearly it's a really robust group of people that are needed to make this program run. However, it does go on to state that the pharmacy should have a leadership role on this particular committee. And I feel that this is justified given the unique position that pharmacists occupy in the healthcare setting, right? So pharmacists have firsthand knowledge of the prescribing trends and the dispensing records in the healthcare facility. We're able to acknowledge questionable prescribing habits from certain individuals or possibly even noticing excessive resupplying to a certain unit. Moreover, pharmacists should be able to identify high-risk medications and make recommendations regarding proper storage and retrieval of those medications. Pharmacists are also responsible for controlled substance inventory, So by implementing frequent and routine audits of all the controlled substances, pharmacists are really able to identify inventory discrepancies in a more timely fashion.
Another way that pharmacists can be involved with the drug diversion program is as educators on drug diversion. So like Chris and I are here today, and that we've done through the Diamond Pharmacy Drug Information Center, we ensure our clients are educated on what is typically diverted, the risk of diversion, and what goes into a really good drug diversion program, and helping with resources to help with addiction. And then finally, as pharmacists, we're able to be aware of various laws surrounding controlled substances. So along with the legal representation, pharmacists are well positioned to create a policy and procedure regarding the handling and reporting of controlled substance diversion if it does occur. So we're really, I think, as Chris mentioned, in a really unique place that we are the drug information experts, and we also can be a really good resource as educators.
So it sounds like something we all need to get involved in, but especially as pharmacists, you guys kind of hold the keys to the kingdom with the information and the data that you have. Erica Gray, Chris Bender, thank you both for being with us here today. We've enjoyed talking about drug diversion. As I mentioned, check out the show notes to find the resources that we have discussed today, and there have been a lot of them. But as always, thank you for joining us on PodcastRx.
Yeah.
Thanks for having us.
Yeah, thank you for having us.
This podcast features conversations with healthcare professionals. Their statements and opinions discussed herein are for informational purposes only. This podcast should not be considered professional medical advice and should not be used as a substitute for the advice of an appropriately qualified and licensed healthcare professional. Therefore, listeners must not rely on the statements made herein.
PodcastRx is a production of Diamond Pharmacy Services, the nation's largest correctional pharmacy provider. Catch our new episodes on Apple Podcasts, SoundCloud, Stitcher, Spotify, or wherever you listen to podcasts. Please rate the show and leave us a review. And if you have a topic you'd like to hear about on the show, or you'd like to share your thoughts on an episode, you can email us at podcastrx@diamondpharmacy.com. Music in this episode by Wolfgang Worley, sound expressed by Getty Images and the 126ers. I don't want to close out this podcast without mentioning something that we mentioned at the top of the episode, and that is that drug diversion can happen at any level. It can happen at the facility, it can happen with healthcare staff, and most importantly, in this segment, just briefly want to mention that it can happen at home. Erica, Chris, would you mind speaking a little bit to just ways that things that we have at home in our medicine cabinet could potentially be a problem?
So yeah, I actually think that's a very fantastic point to touch on, because I mean, it's pretty commonly known that a lot of the younger people, a lot of kids are getting their start by their parents or their grandparents getting these medications for a legitimate medical need, and then just having them so frequently available in the home. So I think it's important, if you or a loved one is coming home with any of these medications, some of the proper storage techniques, of course, as long as you don't have any dexterity issues, is always important to have your medications in a child-proof cap on your vial. So of course, that's going to be a basic level prohibitive technique for your little children. Your smaller children might make it more deterrent for them getting in the bottle. Now, for your older, your younger adult children, perhaps, anyone else in the family, perhaps, if you think there's a potential for diversion, it's not offensive to put your medications in a locked storage container. I think in today's environment, people are becoming more aware that this is a problem, and for the love of your loved ones, you wouldn't want to put them at risk to possibly get their hands on something, even inadvertently. So I think if you have high potency opioids are a very common one. And with this being said, a lot of the prescription habits are changing. So these unnecessary medications in some cases are shrinking in number, but we do acknowledge that these homes still have these medications in them. So I think from a loving, caring family standpoint, it's not a problem to acknowledge this fact and have your medications stored safely in a locked a locked environment.
And I just want to make a mention here. According to a 2018 national survey on drug use and health, 9.9 million Americans have misused controlled prescription drugs. So I want to make you all aware, if you haven't heard about this, that the DEA several times a year does a take back day. And what that is, if you have any drugs in your home that are at risk of diversion, you're not currently taking them for whatever reason you have them, you can drop them off at any approved location, no questions asked, and they will be safely disposed of. And I want to stress, no questions asked. The next take back day is coming around April 25th of this year, April 25th, 2020. You can find more information at takebackday.dea.gov. Once again, thank you for listening to PodcastRx.